lymphoma space, a lot of very exciting themes emerging. We've had bispecific antibodies available to us in later line settings across the spectrum of lymphomas. And at this ASH meeting, we saw both long-term follow-up data for those studies, but perhaps more excitingly, we saw a lot of combination data, both in early phase trials, but importantly also in randomized trials, which helps us to think about establishing those combinations in practice today. As an example of that theme that I was talking about, one in particular that stood out was abstract 0466. That was a phase 3 trial of epcoritamab, a bispecific antibody combined with lenalidomide and rituximab versus lenalidomide and rituximab, which has been a standard treatment regimen for second-line follicular lymphoma. This trial showed us really impressive response rates and progression-free survival that were superior in favor of the epcoritamab, lenalidomide, rituximab combination. The follow-up is still, I would say, relatively early on, but I think really impressive differences even early on in terms of the depth of response and the progression-free survival. So this is a really important, I would say, practice-informing abstract. One of the things we're also going to be looking at from that trial is to look at late infections. We know that when we add a third drug to two, that is one of the adverse events we see, and that was noted in that trial as well. One from the plenary. So when we think about CLL, our most common form of indolent non-Hodgkin's lymphoma, there was an important presentation from the CLL-17 study. One of the emerging themes over the last few years in frontline treatment of CLL has been this dichotomy between fixed duration treatment or continuous therapy with a BTK inhibitor. This trial looked at two different fixed duration combinations, either venetoclax and obinutuzumab or venetoclax and ibrutinib compared to continuous monotherapy with ibrutinib. This study was designed to look at non-inferiority of the VO combination and ultimately met its primary endpoint. So importantly, I think what we take away from this trial is probably practice affirming. Patients don't lose anything with fixed duration therapy compared to, say, continuous BTK-based monotherapy. I will point out that when we were looking at different subgroups from that data disclosure, there may be some differences there that are important for us to dissect out, and ultimately a lot more to come from that trial, but importantly supports the idea that a fixed duration treatment regimen can be as effective as continuous therapy for most patients with CLL. A lot of really exciting things happening in the field. We've now had CAR T-cell therapies for almost a decade, but we saw a lot of data disclosures on next generation CAR T products for lymphoma, in particular what we call dual antigen targeting CAR T-cells. So these are CAR T-cells that target two or more tumor proteins, and we saw increase in the depth of responses from some of those CAR Ts that have disclosed updated data. We see improvements in the safety profile of these CAR T cells, and these CAR T cells are now going into head-to-head trials versus the approved CD19 CAR T cells in diffuse large B-cell lymphoma. So very excited for what's to come from there. And then I'll also mention briefly, there's been a lot of buzz on in vivo technologies, and there was in the late breaker an in vivo CAR T abstract. This one was in myeloma in a small number of patients, but I think that abstract really serves as a great proof of principle for what in vivo CAR T cell could be, and there are also in vivo CAR T cells being developed in the lymphoma space.